My name is JLabieniec, the Vice President of Acute and Forensic Services here at Continuum of Care. Really honored to be here to share some of our experience and expertise with working with first break psychosis. I've been with Continuum for over 17 years, overseeing our crisis programs and our acute residential treatment programs. Continuum of Care is an established organization for over 55 years. We specialize in residential and crisis care for individuals with serious mental illness and co-occurring addiction. I also work on a small little private practice to continue client contact, and I've also had some experience in working for mobile crisis. Most of my experience came from working directly in our crisis residential homes, and what that is a diversion from inpatient hospitalization, collaborating and working with emergency rooms and hospitals to try and keep clients from unnecessary hospitalization. And over the years, this has become my passion to really help foster people stabilizing in the community. I've really learned the value of being able to live with our clients. And by that, I mean, in a 24-hour residential setting, I feel like we're really able to make an accurate assessment and build rapport and trust with individuals, which in my humble opinion, is the most valuable factors in the recovery process. So we will get started here. I believe I'm going to be joined by Krista Luna shortly, and we're going to go through this short webinar. We only have an hour, so I'm going to try to go through this quick, and if anyone has any questions, we will get to them at the end. So thank you again for joining us, and I'm going to go ahead and share my screen. So in understanding first break psychosis, we are looking into the research and best practice, but more importantly, from the eyes of the client who is suffering. So I thought in my research, I had found a really striking survey through NAMI, where they had found that approximately 40% of individuals who experience psychosis said initial insight came from them themselves. And I feel like that really puts a perspective and highlights the recovery process for individuals, that it's not so much what we are doing aside from support and walking with them in their journey and trying to intervene, but the initial insight had come from them. I thought that was a really striking number. And when asked who was most helpful in the process in the early stages of psychosis, clients had reported no one. Which really speaks to the level of confusion and isolation that people experience when they're undergoing a first break psychosis. The other striking thing that I found was when they were asked what was most helpful, most responders had answered finding early help, listening patiently and compassionately, keeping them from harming themselves, providing a safe place to recover and rest, building trust, and making suggestions without being confrontational, remaining gentle and calm. So again, really putting a perspective from the client's eyes who may be experiencing a first break psychosis. So to put things into some general factors specific to first breaks, most people experience their first episode of psychosis in adolescence and early adult life. We usually see people in their early 20s. The first episode of psychosis is extremely confusing and traumatic experience for the person and their family and causes considerable distress and disruption. Early appropriate treatment can reduce the degree of disruption and morbidity created by the psychotic illness and can result in a more rapid recovery, more favorable outcomes. Current research does indicate that early treatment does not occur in most cases, with symptomatic individuals remaining undiagnosed and untreated for a longer period of time. And delays for up to a year are common. The first episode can be conceptualized as usually occurring in 3 phases, which we'll talk about: the prodromal phase, the acute phase, and recovery. Treatment of the first episode requires a comprehensive biopsychosocial approach and a range of specialty treatments aimed at treating the person's primary psychotic symptoms and assisting them in overcoming their secondary personal and social difficulties, which the illness often creates. What I had found that, really considering grief and loss when working with an individual, and how important the family therapy aspect is in really collaborating as a whole team. As a young adult, many people are experiencing changes as it is, and it's a very difficult time in an individual's life. So to go through a psychotic episode and have your life changed, there's a really great book called Ambiguous Loss that talks about other losses in one's life, and really that grief of losing your adolescence and your childhood to a psychotic illness. So these phases of psychotic episodes, 3 phases. So these are usually, to put into perspective, the phases when an individual is experiencing the first break, which are deferring to as the onset of a psychotic disorder. Sorry. So these phases are when we see somebody that's developing a schizophrenia or schizoaffective disorder. So the prodromal phase can last months or years and might include social withdrawal, difficulty with concentration, sleep disturbances, odd behavior, mood changes, anxiety, and deterioration in function. Many times hard to notice. The acute phase is an onset of overt symptoms, usually positive symptoms, which we'll review a little later. Delays in access to treatment are usually related to the individual being suspicious and guarded, or attempting to conceal difficulties. Reassurance and gentle persistence may be necessary. Focusing on the concerns raised by the individual and respecting their point of view is usually a fruitful approach. And then the recovery phase. Sometimes there is an abrupt improvement, symptoms are gone. Most times there is a gradual dissipation of symptoms. So recognizing first episode psychosis, some of the kind of red flags to look for: neurotic symptoms, anxiety, restlessness, anger, irritability, mood-related symptoms, depression, guilt, suicidal ideation, mood swings, changes in volition, apathy, loss of drive, boredom, loss of interest, fatigue, reduced energy. We see cognitive changes, a lot of physical changes, obsessive compulsive. Preoccupations is a very common one when people begin to experience auditory hallucinations or hearing voices, and a lot of behavioral changes. So many ask why is it so important to treat early? And all of the research has shown that early intervention has better outcomes for young adults. Wraparound services is the approach that is most effective. Residential care to be considered for folks to get that wraparound assistance and discharge planning and get everything in place for an individual before they return home. Helping them to create purpose and connection. Again, going back to grief, something I think is really important, something we've been talking about in our treatment program in terms of helping to have young adults acceptance to their illness. And I can't stress enough the importance of family support. These wraparound services, we're talking about medication and primary care, psychotherapy, family education and support. NAMI is just a wonderful resource for families. They have a family-to-family educational program that families can sign up for to learn about mental illness and interventions and how to cope. Supported employment and education, again, very important when we're looking at purpose and connection. Continuum actually has a peer mentorship and peer work program where My ongoing joke is if clients stay with us long enough that we will find them a job and we will put them on payroll. And of course, case management and peer support, extremely, extremely important to give them those wraparound services that they need. So in looking at schizophrenia and other psychotic illnesses, we look at positive symptoms and negative symptoms. Positive symptoms being hallucinations, delusions, disorganized thinking, and abnormal motor behavior. More commonly, what we see is the auditory hallucinations, especially early on, where people are very distracted and possibly responding to internal stimuli, hearing voices, or having delusions like false beliefs that are not based in reality. Feeling that the phone is tapped or the CIA is out to get them. I worked with an individual on his first break where he believed his grandmother who passed away was communicating with him. Very scary, scary time for young adults. And those we refer to as more of the positive symptoms. The disorganized thinking is something we see as well, where individuals have a very difficult time following a linear conversation. And negative symptoms. Affective deficits is something that we see a lot, often very flat affects, no range of emotion in people's presentation. And a lack of motivation is the other one that can often be confused and mislabeled, which is a little pet peeve of mine, as laziness. Individuals who have difficulty cleaning up after themselves, have difficulty showering and bathing and keeping up with their ADLs is actually a symptom of their illness, which we refer to as ovulation. No difficulty pronouncing that. There's also a common symptom, hedonia, which is defined as a diminished capacity to experience pleasant emotions. So those are all deferred to as negative symptoms for psychotic and schizophrenia. How can psychosis and other serious mental illness affect a person's life? The first episode of most major psychiatric illnesses occur in adolescence and early adulthood. When left untreated, it can lead to a lower quality of life and shortened lifespan. We see loss of employment, withdrawal from school, loss of relationships, decreased physical health, sometimes criminal justice issues especially when co-occurring and substance use come into play. Increased utilization of the emergency rooms and a need for longer-term care. Recovery from psychosis is a very gradual process that is unique to each person. And I think that is one of the most important things to keep in mind when working with somebody who is trying to recover from a first break. It's unique to them. And what we have found most successful here at Continuum in terms of working with and living with individuals is that it takes a lot of patience to walk with people through their journey and their acceptance of their illness. We see a lot of individuals on and off medications and having multiple hospitalizations. But what has been most successful for us is to continue to work with them throughout that journey, to not judge them, and to continue what I like to say is wrap our arms around people during their process. So co-occurring, a lot of the individuals, especially young adults, struggle with substance use. Most common is alcohol and marijuana. I put the marijuana phenomenon in synthetics because synthetics are a big problem for us today. Young adults can purchase the dab cartridges, which is a way to vape marijuana, and often has no smell to it, and you don't even know that folks are using it. The other concerning thing is that it's highly potent. There was a study in the UK that linked high potency marijuana to first break psychosis, especially those that were susceptible to psychotic illness, usually through genetics, family history. People who used cannabis on a daily basis were 3 times more likely to have a diagnosis of first episode of psychosis in this UK study, and compared with people who had never used cannabis. This increased up to 5 times more likely for daily use of high potency cannabis. And I think that's a lot of what we're seeing today, especially in the emergency rooms, is a lot of psychotic episodes for folks that are smoking, and young adults, especially, that are smoking this high potency marijuana. Studies have found that 60 to 80% of young adults with first episode psychosis report using cannabis, 88% report using alcohol, and 70% tobacco. A person can have more than one illness, more than one mental illness, whether that be a mood disorder or a other thought disorder. And I put in here a colossal failure of integrated treatment. I am a big critic of our treatment system, and the failure that we, in the 1980s, integrated treatment, meaning the treatment for substance abuse and mental illness, the research had suggested that integrated treatment was the most effective. And here we are in 2021, and we still have separate facilities for substance use and for mental illness, which is really disturbing. Effective strategies. So when we talk about working with individuals that have their first break, shared decision making is just so incredibly important. The treatment plan is developed with the client, and this includes their thoughts, preferences, desires, and goals. And this is the way we build rapport and buy-in. Without that relationship, without the buy-in, the treatment is helpful, individuals are not going to want to remain in treatment. And that is probably why we see high hospitalization and high emergency room visits, is because people fall out of treatment. And they fall out of treatment because they feel they're not heard. They feel they're not a part of the process. The other very important factor is helping families understand the process, and sometimes the necessity for harm reduction. So what do I mean by that? Families are devastated. I actually spoke to a family early this morning that had called me, just devastated about some of the things their 17-year-old son was saying. And the support has to come for the family as well as the client, separated and then jointly. As a parent of a child who has mental health issues, I can't tell you how helpful that was for my family, to get my son help and to get my wife and I help, because it's when one person is sick, the family is struggling, the family needs support. Harm reduction is a very, in the residential world, there's no real research on harm reduction in residential settings. And what I mean by harm reduction is sometimes folks struggle with the acceptance of their substance use and how their substance use and abuse may be affecting their lives. The insight is not there to why using is causing them harm. And as providers, myself as a clinician, to push the recovery process is sometimes going to push people away. So by harm reduction, we mean that we are going to try to continue working with the individual. We're going to try to continue to support them during their use. And that is sometimes a very, very difficult pill to swallow for families, because they struggle with understanding why, there's nothing being done about it. And the goal in harm reduction is to continue the treatment process, is to continue the trust, the rapport. And we like to practice, especially when it comes to substance use, but also the insight with psychosis that I talked about earlier. When people do not believe that they have a psychotic illness, which is a symptom of their disease, to not think they need medication. The goal is to continue to work with them, to try to support them, and to try to use an approach called motivational interviewing to help them see how, when they were on medications, their life was more manageable. So again, sticking with people through that process is very difficult. It requires a lot of patience and a lot of support. So I think it's important for families to understand what harm reduction means, especially with co-occurring disorders, because I always refer to it as the double whammy. I mean, you have a child that's struggling with their first break of psychosis, and they also have a substance use problem. Both illnesses, there's poor insight, and that's an extremely frustrating and difficult process. I put in here, families are and should be considered an important, vital part of the care team. And that can be a controversial statement because of HIPAA. And sometimes when folks are psychotic and paranoid, they may not want families involved in their treatment, and they may push their families away, which is understandable, and we have to respect that. But at the same time, families should not be shunned. Families should not be pushed away. Families should have access to their own support and continued collaboration, and they should be a part of the team. A lot of families are an intricate part of a person's recovery, and that, there's two extremes to that, because sometimes the family may be more disruptive in the recovery process, and that's where the education and the support comes from. If they have their own treatment, their own provider, getting together and collaborating with that provider to educate them, to give them the support they need and to help them through that process and get their buy-in on what's going on and what's going to be most helpful. Very easy to say, very difficult to do. It is important to incorporate the client's own goals into the treatment plan, psychosocial programs and therapies, both in an individual and group format. Also, equally important to consider social and vocational programs, and to consider the development of a client's own strengths. What I like to do with clients that I work with is to help work with them in developing what I call disciplines. And your disciplines are healthy outlets, they're healthy coping skills, and they're tools that are going to be in your tool bag to help you when you're struggling. Always deferring back to what are your disciplines, what's helped you in the past, and how do we get back to that? Or helping them understand what healthy disciplines mean and what that means, and incorporating a new way of living and coping with psychotic illness. Medications with psychotic disorders are often very necessary. It is sometimes difficult to diagnose a psychotic disorder that's could be developing schizophrenia when substances are involved, going back to what we talked about with the marijuana use and how high potency cannabis can cause psychotic symptoms, PCP can cause psychotic symptoms, methamphetamines can cause psychotic symptoms. So it's often very difficult to get a handle on a diagnosis if somebody is using a lot of substances. And we see that often, where sometimes medications are needed in the beginning, and as somebody becomes clean and sober or starts to recover from their substance use, they may not necessarily need medications. That's a tough road to go down. It's very difficult, and that's where that whole team approach is so important, and working with the family and really building a rapport and trust with the client. And that's where I feel that the residential treatment can be your best bet, because when you have somebody that's living in a program 24/7, you really are able to get an accurate diagnosis. And then underneath that, the neuropsych testing, that's often another very, very helpful tool in helping to formulate diagnostics. Neuropsych testing is a separate discipline from what we do in the social work and field. It's a battery of testing that helps to really get a pinpoint on a diagnosis from that perspective, and they often make recommendations as well. And the recommendations can be helpful in terms of looking at what you're doing in the treatment plan and what you can maybe incorporate with the neuropsych testing. So it is often a tool that we access very, very often when there is some question of diagnostics or some question of what might be going on. I put here remaining active and involved in the journey. Again, first break psychosis, developing schizophrenia, what we see very often is a phase of treatment that includes on and off medications and a resistance to treatment, and emergency room visits and hospitalizations, which is incredibly stressful on families and providers. Remaining active and involved in the journey helps to establish trust with the family, with the individual. When you stick by somebody during that process, just like in substance use, your chances of assisting them in their long-term recovery are just that much greater. Avoid multiple treaters, find a home, find a multidisciplinary team that's going to remain active. One of my pet peeves is often hearing that somebody needs a higher level of care. And that may be true, but that does not necessarily mean that they should be discharged and have to start over with a new team. That's often probably the most counterproductive tool to use when working with individuals, is discharging them and having them start all over again. It really disrupts the recovery process. The value of peer support, and what I mean by peer support is other individuals with lived experience that can help support an individual in their journey and their recovery process. I mentioned that Continuum has a peer program. We have peers that work in all of our residential sites, and they often become the go-to person for folks. I was over at our crisis house yesterday doing a tour with somebody from the city, and the program manager, when the person asked about having folks with lived experience working in the programs, had said that she just had one of the clients come up to her in the morning and say, when is so-and-so coming in, because I need to talk to them. And that was the peer support staff, person with the lived experience, the person that may be able to understand the individual at a much different level. Lived experience is something that we cannot learn as providers, as family members. We cannot learn we cannot learn that lived experience. We don't know what it's like, and we shouldn't tell them that we do. But to have a peer support person, to have a mentor, to have somebody with lived experience that is in a longer term recovery is the most valuable thing you can have. I also put in here, consider alternative interventions and crisis planning, whether that be residential, in-home support, case management, recovery support. The value, knowing that the journey may be a very difficult road, having that crisis plan in place ahead of time is going to be very valuable. And what should be a part of that crisis plan? It's often knowing what you're going to do when the crisis occurs. Often 911 is the go-to for psychiatric emergencies. And I know that in the state of Connecticut, we're trying to change that. They're coming up with 988, which is going countrywide, to help there be other supports besides police and EMTs, to have that discipline on a team to come out during a psychiatric emergency and really assess on whether or not the person needs to go to the emergency room. Often, by no fault of their own, emergency rooms can be devastating and traumatic. The individual I work with, that I still work with, that experienced his first big 3 or 4 years ago, was in the hospital one time. He's been in residential care twice. He was only in the hospital once, and it was the worst experience. And he said he never wants to go back there. And again, that's not necessarily the fault of the hospitals. I think you have a lot of disciplines working in the emergency rooms. You have it's a very, very stimulating environment. And what we have found to be most effective in residential treatment is keeping that stimulation low. So having a lower census, finding a facility that doesn't have 38 beds and 3 people to a room. For somebody suffering and struggling with psychosis and paranoia, having 2 roommates is going to be very, very challenging. Being in an ER hallway and having 100 people walk by you can imagine how devastating that must be for somebody who's paranoid and delusional and terrified. So considering alternatives is really going to be your best bet. And it doesn't have to be continuum. I think there's residential care throughout the country, and finding the right place where people are going to feel safe. Going back to that NAMI questionnaire, having a place to rest and feeling safe, and helping them not hurt themselves. Those were answers by folks themselves who have suffered with psychotic breaks. And going by that, you want to have a plan. You want to have a plan of where somebody can go and who you're going to call. When 911 is utilized, I always, in Connecticut, we have what we call CIT officers, and I know that is a countrywide thing. And what CIT officers are crisis intervention officers, treatment officers that are trained with mental health and have a little more expertise in working with individuals that may be struggling with any type of mental illness. CIT officers can be very, very effective. And mobile crisis is another one. I worked for mobile crisis for many years. And what I am excited about with the 988 project is that there's three phases. There's the call for the psychiatric or the suicidal issue. There's a mobile dispatch, and then there's a place for somebody to go. And they're trying to avoid hospitals and emergency rooms. That's a much better trajectory for our clients. It's a much safer one. It's all the way around. It's a very good plan, and I'm very excited about it. So those are some of the effective strategies, some best practice and research, some of what we've experienced in our own and working in our crisis and treatment programs. So medications, again, medications are often a necessary evil, is what I like to say, because antipsychotic medications have a lot of side effects. And those side effects are very devastating, especially for young adults. Those are the primary medications used for psychosis are antipsychotics. The initial goal of treatment with an antipsychotic medication is to reduce or eliminate symptoms and allow a rapid return to best level functioning. Best level functioning does not mean that the person is going to be where they were prior to their psychotic break. And it's something we refer to as baselines. So when somebody is recovering from a psychotic episode and antipsychotic medication intervenes and treatment and they stabilize, we then defer to that as their baseline, and that's their best level of functioning. Over a long term, antipsychotics can help to prevent further episodes of antipsychotics. And going back to reducing or eliminate symptoms, antipsychotics can help with auditory hallucinations or hearing voices. They can very much, what clients have said is really reduce the loudness of the voices. I know there's a better word for that, but they can also decrease paranoia and delusions. Sometimes they can eliminate them, and sometimes they reduce them in an effort to have the client function better. The client might need to try more than one antipsychotic medication to find the right one. And we find that this is true with every illness across the spectrum of mental health. Individuals are unique, and finding the right medication is a very, very frustrating process, not just for folks that suffer from psychosis, but for anyone. Again, going back to my own personal experience, my son had a trial of many, many different medications before finding the right ones. And I will say, as a parent, that finding that right one was really a blessing, and it made that difficult period of experimenting and having a person feel like a lab rat. It in some ways made that much easier to cope with. To see them stabilize and see a medication that is effective. And it's the same with psychosis. There are many medications that become the right medications. For psychosis, it's much more frustrating because if somebody is not on a right medication, they may decompensate and end up back in an emergency room or a hospital, or hopefully a residential treatment program where they can try a different medication and keep the person safe. The client might need to try more than one antipsychotic. I already said that one, I'm sorry. Long-acting injectables are always, well, from our experience, have always seemed to be a good option for clients that have trouble taking medications regularly. There are several different long-acting injectables that can last 30 days and now up to 3 months. And these injectables are taken only one time. And for folks that struggle with that acceptance of the illness, sometimes those injectables are a really good way to help keep some period of stability that you can defer back to. So we have found some good success with that. So medications have side effects, and antipsychotics have some really, really difficult side effects. And this is often what we hear our clients saying. And it's about weighing out the pros and cons. Patients might experience side effects while taking certain medications for psychosis. This is normal, but should be shared with the prescriber. Individuals taking antipsychotic medication can experience one or more of the following symptoms. So these are all real side effects, and not to say that every client is going to experience one of these or all of these, but they may. Dystonia is uncontrollable contractions of muscles, Parkinson-like symptoms, tremors, and slow movements. Akathisia is a feeling of just overall restlessness. Tardive dyskinesia is uncontrollable movements that usually occur in the face, neck, or tongue, and of course, sexual side effects. This is something that a good prescriber, a good psychiatrist is going to monitor on a regular basis. Every time they meet with them, they're going to review these things. They're going to ask the clients to put out their hands. They're going to check for any of these side effects. Psychotics can also have metabolic side effects such as weight gain and diabetes. And this is, again, often a very, very difficult thing for clients. Managing a accurate diagnosis on first break is often very difficult. If there is a co-occurring mood disorder, oftentimes Depakote or lithium is kind of the missing piece to sustaining some recovery and stability. So resources and support is really beneficial for families, for treaters, for everyone involved in the recovery process. Just to kind of summarize everything, finding appropriate wraparound care, not an easy task to do in our world of care and services. Finding the right providers that will continue to follow and support the client. It's hard, and I know this as a parent, looking for a prescriber, looking for the right therapist. My son had gone through 5 different therapists before he found the right one, and had gone through multiple prescribers. It is very difficult in this day and age to find a provider that's going to call you back, a provider that's going to be there. But they exist, and I was able to find them, and you can find them too. And it's difficult, but for those of you who do work in the field, be that provider. Be the one that is actively involved. Be the one that is going to return the phone calls, even if it's after hours. I know that's a controversial statement, but this is the field that we signed up for, and I think that making yourself available during a crisis is an ethical duty. Some pet peeves of mine and trigger words again, saying somebody needs a higher level of care. What does that mean for the trajectory of their treatment, and what does that mean for you as a provider? Are you going to stay involved? Are you going to call the hospital to check in? Are you going to be part of an all providers meeting? Are you going to be a support to the family? Treatment ultimatums, another little pet peeve of mine. Very tough to do when somebody may be struggling with substance use or conduct disorder. But ultimatums, in my opinion, push people away. Motivational interviewing is a tool that is very, very effective. The research backs that up, and it's a way to help clients get buy-in. Going back to the NAMI survey, 40% of clients found insight on their own. When it comes to psychotic breaks and psychotic illness, lack of insight is one of the most common problems, and it's one of the most common symptoms that cause clients to go on and off medications. And if a majority of clients find that insight on their own, what does that mean for us as providers? That means we need to walk with them through that journey. We need to support them, not give them an ultimatum. So some other ways to summarize this, preparing for the journey. Again, I go back to considering grief work, the book Ambiguous Loss. Clients are going to go through a journey, and they're going to find acceptance, but they're going to find it through their own journey. And I think as providers, it's our job to walk with them through that journey. It's our job to support them through that journey. The other important factor to highlight is having a crisis plan and knowing the resources. My experience has been over the years working in a crisis setting that collaboration is really key. Collaboration is the key. It's the glue. It's the thing that's going to keep everything as together as it can be. And collaboration means collaborating with the police. It means collaborating with other providers. It means collaborating with hospitals. It means collaborating with emergency rooms. It means making friends, not enemies. And in this day and age, when there's caseloads of 150 and there's wait lists and our system has more barriers than we can handle, it's difficult. It's not an easy task. But forming those collaborations is going to help you and us as providers. It's going to help our clients. That was my lesson in working in the crisis programs, that our program could not help a client move forward if we didn't collaborate with community providers, if we weren't a whole, if we weren't working together. So collaboration is absolutely key. Those are my summarizing statements. And up on the screen I have here, we have another webinar coming up on managing clients with acute symptoms in the community, the art of verbal de-escalation. We have two of my counterparts, Leanne Parent and Melissa Ortiz, both trained in Handle with Care, emotional first aid, and crisis co-regulation. And they'll be providing an hour-and-a-half webinar that I believe has a CEU, earn one CEU. So if you're interested in that, there's an email at the bottom here, scollier@continuumct.org, or you can find it up on our website. And I believe we are done. So if there's any questions, I believe Rista is here with us. How are you, Rista?
Hi.
We have questions.
So, yeah, if you guys have any questions, you can either type them in the Q&A or put them in the chat, and I will either read them for John or we'll send you the information you need later.
One of my experiences in, many of my experiences in working for mobile crisis, a lot of, I know we have people from all over, not just from Connecticut, but they're going back to the collaborative piece. Often what wasn't necessary for us to do as mobile clinicians was to follow up with the ER. So if somebody was papered against their will for a psychiatric evaluation, it was not expected of us as mobile clinicians to reach out to the emergency room or to have any follow-up, which to me was very, very disturbing. I tried to change that to the best that I could, and I know it's, you know, it goes back to that kind of ethical responsibility for being collaborative in my mind. So calling over to the ER and talking to somebody in the psychiatric emergency room to give them an idea of what was going on, and I would often leave my number for follow-up.
John, we have a question. Are there gentle ways to help with gaining insight?
Gentle ways of helping to gain insight. Well, I think, you know, from my experience, and Rista, please jump in, the motivational interviewing is a very effective tool. It is a very best practice and research-based form of communication that can really help people to gain that insight. You know, in terms of kind of pointing out discrepancies, hearing the client out, and trying to help them in terms of seeing how You know, whether it's stopping medications or returning to active substance use, you know, really helping to develop discrepancies. And, you know, I often used to do a pros and cons list with one of my clients who had a first break and also struggled with cannabis use. And it was very, very enlightening. And he got to the point where he would do them himself. And he's, you know, now he still struggles with gambling. He kind of put down the marijuana and now he's gambling. And I met with him last night, and, you know, right away he started weighing out the pros and cons of gambling. And he was really able to see how devastating gambling, what an impact it was having on his finances and his inability to purchase a car. And so, you know, that's been, it depends on the client, I guess is what I'm saying. It really depends on the client and what's going to work. For this individual, the pros and cons list is extremely helpful for them developing better insight. I don't know if you have any other thoughts, Krista.
The only thing that I can add to this is that sometimes also just gently making evident the discrepancies, like you said, in what, you know, what's going on with them, without proposing necessarily what you think is best for them, but just, you know, you are telling me that you don't want to, you know, be in trouble with your probation officer, and you're telling me that you don't want to take your medications. How do we fix this? You know, so that they can come with their own solution, or they can buy into the proposed solution that they will bring up. And sometimes, you know, what they come up with is not necessarily what we think it's best or what we would have come up with. We had clients in a residential program that sometimes, you know, work with us and stay with us and stay committed to treatment, but don't necessarily do what we initially thought is best, but they stay engaged, they stay working with us, and eventually get there. And they get there because they wanted to get there. So I think there's work on sort of letting them get there themselves by making their own decisions.
Thank you. I'm not able to see the questions, but I guess there was another one. Do you have any resources or information on how to speak to someone who is experiencing delusions? And there is some good stuff out there on the web that if somebody wants to send us their email that I can direct you to. Our approach has always been not to confront delusions, and what we do as social workers is to really assess on whether or not those delusions are going to impact safety. And if they're not going to impact a certain person's safety or their ability to keep themselves safe or harming others, then the delusion is the delusion, especially fixed delusions. It's not anything that we're going to change, and it's their belief, it's their understanding. So that's been often my approach with delusions. It's really an assessment that's most important, not so much what their delusion is.
And I think we have another question that is kind of similar. You gave an example about grandmother speaking to them directly, and this question says, let's say person says, they say God speaks to me through music, like the grandmother's favorite song was playing on the radio. How is that different from the example that you gave before?
I don't think it's different. I think it's, you know, it's pretty much, it's different, but it's the same. It's a false belief. And again, I go back to assessment. You know, my first question is, you know, kind of what is God saying and what does that mean to the person? So again, I think you really want to go back to your assessment. Some people have fixed delusions that aren't going to go away, and that's going to be their reality. And our job as providers, from the clinical component, from the psychiatrist, prescriber to the clinician, is to really gauge the impact that delusion might be having on someone. So if God is speaking through music and the song is playing and it's telling him to go, you know, to hurt himself or to hurt other people, or he believes the message is that he needs to end his life, those are the things we are assessing. If it's simply his grandmother speaking to him and it makes him happy, you know, there's not much concern to have. So that's how I would handle
One thing that I can add, it's also that it depends of what you're doing. If you're doing a crisis assessment, I wouldn't focus that much on trying to contest the delusion as much as I would focus on gaining rapport and getting them to a safe place. In whatever the delusion reported is kind of not important at the moment. You want to either then touch base with the psychiatrist, go with you to the emergency room and get in the ambulance, and that's what you're focusing on. And I think that the best approach is, because they're already having all this other stimulation that is not from the environment, your approach has to be very concrete and very simple, because otherwise they are hearing all these things and they're thinking all these things. You're really just one stimuli among many. So it's sometimes it takes the least you say, the better. Can you please get with me in the ambulance, or can we call your psychiatrist together? That's all you need to do. You don't really need to do much about anything else at that moment.
Right. And I know that can be very difficult for families, for case managers or life coaches or other people in the field that may not be directly involved in the treatment. And that's where I go back to be a part of the treatment. Be a part of that team so that you have an understanding of that delusion, so that you know that maybe this is something that the person is going to struggle with. If you're a part of the process and involved, you are going to have a better sense of what that means for the person. Again, going back to fixed delusions, those are things we are not going to change, but we need to understand them and we need to assess for them. If you are not the person to assess it, you really need to follow up with the clinical provider and the psychiatrist. And again, that goes back to being a part of the process and having somebody available that's going to pick up the phone. I know that sounds crazy, but many of you may know where I'm coming from, because if you don't get a return call back for a week, then that's a problem. You need to find another provider. You need somebody that's going to call you back. My son, I finally got him connected to a therapist that is available, and she's always available. He had a crisis a few months ago on the weekend, and I had sent her an email, and she actually called me and did a session with him on a Sunday to check in with him. That's the kind of provider you want to find.
Yeah, and if I may add that, I think that's important also in college, especially in college, and some of the college counselors that have kids that are away from home. I think what's important is to find a college that has a counseling service that is able to connect those kids quickly to the services that they may need if there is a crisis, and it's not automatically just take this kid out of campus and take him to the ER, but give them the services that they need. I did have a similar experience with my daughter in junior year. Her medications stopped working completely, and she needed to see a psychiatrist, and she was in Indiana, so it's like, this is going to be hard. So luckily the school was responsive enough to get a psychiatrist to meet with her, to get on the phone with me and change the medications on the spot. And really that made a difference in terms of her having to take the semester off and being able to stay in school and completing, graduating basically on time. So I think that that's the role of the school counseling centers as well, like being able to have the access to the services on site to prevent a major crisis.
Mm-hmm. I'm going to send in the chat box my email address and also my cell phone number. I'm always happy to take calls when I can and collaborate with other folks and be as helpful as I can in the process. We got about 5 more minutes if there's anyone else that has any comments or questions, recommendations.
And I guess we can send resources to everyone of online websites that can help with resources and things like that, and local resources as well. We can put a list together and send them to you. Oh, there's a silly question, not really. It says, this might be a silly question, but I noticed eye changes in my son prior to his first psychotic break. Is that something that parents, teachers could watch for?
Um, I think, when it comes to psychosis and first breaks, I think and I'm so glad that there is a parent on here too. I think that you wanna be a part of the team and you want to talk about those things. It certainly could have something, it could be something to look for, or it may not be anything. It's hard to kind of say, but I think when you have a good relationship with your treatment team, those are questions you should ask them. More than likely, I as a parent and as somebody that has a son, I was like that as well, and I probably still am, where you start to notice things and you get worried and you get concerned. And prior to my son being diagnosed, he had he went through a sleep study and he had brain scans because he did that when he was younger. He had some weird eye movements that made us think he was developing autism or something, and it all turned out to be normal. Whether or not that had any impact on him developing, OCD and anxiety and depression, I don't know. I don't know that answer. It's certainly something that Rista and I can maybe take back to the psychiatrists we work with to see if if there's any research.
Yeah, I would say for parents and providers that are not psychiatrists, it's good to notice these things, because sometimes they might be, they might be anything. There might be something medical that is going on with them, but also it might be a sign that they're responding to internal stimuli in a certain way, or with OCD, it might be part of the rituals. So it's good to notice and report, but it's hard to say that's definitely a symptom without, context and without having a medical assessment. But yes, I think that our role as parents and providers and case managers is to notice those changes and report them, so that the early we notice that things are changing, we can, intervene early as well.
And it's funny, I'm a social worker, and I often have my son's social worker saying to me, relax. And I need to hear that, relax, he's just a kid.
We have another question. It says, how has the isolation of COVID impacted people? My son has not been able to go to school, is playing video games to stay connected to friends, and it's just so down.
Well, my son is 13. I have a 10-year-old too, and I can certainly say I agree. I think that children and younger adults that have struggled with any type of anxiety, depression, or have been impacted with mental health issues, COVID is going to have an impact on them. The isolation is just devastating, and I think we're still going to see the aftermath of that. It certainly has brought more people into treatment. It has been, in our experience, a cause of decompensation in a lot of our clients. The isolation is devastating, especially when you're struggling with mental health issues. I always, I'm a big, my kids hate it because they're like, oh, are we gonna have to talk about this? But I think, finding help and talking to them and really trying to assess on whether or not it's something you need to be worried about. Accessing the school social worker, accessing any type of outside supports that maybe somebody else can come in and do a quick assessment just to see if there's anything that you need to be worried about. It doesn't hurt, especially during this time with COVID, because it has had a devastating impact on people. So if there has been a history of mental health issues, I would pay attention to that and try to get, try to talk to them yourselves, or try to have somebody else talk to them. Any other questions or comments?
Yeah, I think we are good.
Thank you, everybody, so much for attending. We were really
Did you see one on COVID?
Yep, we just answered that.
Sorry, I was distracted.
And there's somebody from the UK. That's wonderful. Really excited to see so many people joining us. I hope that our experience and our expertise in this realm has been helpful. Again, I put my email and phone number, and I'm not joking when I say I don't mind getting a call to collaborate or to try to help with situations or offer some of my feedback. So thank you everyone again for joining. I hope that this was helpful and beneficial.